Hi guys, welcome to Easy Medicine. The topic for discussion today is the liver function test. We'll see what are all the tests that are included under the LFTs and what are the patterns of elevation in the liver enzymes and how are they useful for the diagnosis. So starting with the liver function test. So what are all the tests that are included here? We have bilirubin, aspartate transaminase, alanine transaminase, alkaline phosphatase, 5' nucleotidase, gamma glutamyl transpeptidase, PT and INR, and we have, of course, the serum proteins that is albumin and globulins. The albumin is a more important one. So the bilirubin will tell us the kind of metabolism that is happening inside the liver, and elevation in AST and ALT will indicate the liver injury for our practical purposes, and elevation in the further three enzymes that is alkaline phosphatase, 5' nucleotidase or gamma glutamyl transpeptidase will indicate that there is cholestasis inside the liver, right? When these three enzymes are elevated, we call it as a cholestatic pattern. So, and then PTINR and albumin indicate the synthetic function of the liver. This is a brief outlook, and let's dwell into each and every one, starting with the transaminases. So we have the AST, that is aspartate transaminase, otherwise called as SGOT, and other is the ALT, alanine transaminase, also called as SGPT. This AST or SGOT is produced by multiple organs, that is liver, skeletal muscle, cardiac muscle, lungs, pancreas, kidneys, and RBCs. Since this AST is produced from multiple organs other than the liver as well, the elevation in AST is not very specific to the liver injury. Whereas elevation in ALT or SGPT is primarily from the liver, and hence it is a more specific marker of liver injury. Now, the normal levels of AST or ALT can be in the range of 10 to 40 units per liter, but the elevation in AST and ALT will indicate different hepatocellular damage patterns. For example, elevation in the AST or ALT up to a range of less than 300 can be very non-specific and can be seen in any kind of liver injury, commonly seen with fatty liver disease, sometimes in celiac disease, as well as in hypothyroidism, right? Whereas the levels more than 1000 indicate that there is a severe hepatocellular damage. So now we have to look at the specific liver diseases. Commonly, they are viral hepatitis or ischemic hepatitis, sometimes toxin or drug-induced hepatitis, acute biliary obstruction, and Budd-Chiari syndrome. These are some of the most important causes that will result in a severe hepatocellular damage. Now we are looking at the AST to ALT ratios. It is important to look at the AST to ALT ratios because that will indicate whether there is an alcoholic etiology here as well. So let's delve into it. The AST to ALT ratio more than 2 indicates that there is a suggestive of alcoholic liver disease. Okay, when the AST to ALT ratio is more than 3, it is highly suggestive of an alcoholic liver disease. Why? We'll understand here. See, in a liver injury, both the AST and ALT will be increased, but specifically in alcoholic liver disease, the ratio is more than 2 because there is decreased production of ALT. Because increased intake of alcohol will result in the deficiency of pyridoxine, and this will further result in the deficiency of pyridoxal phosphate. This pyridoxal phosphate is required for the production of ALT, and hence the ALT elevation is lesser because of this pyridoxal phosphate deficiency. Relatively, AST elevation will be high, and that is clear in case of an alcoholic liver disease. But what happens in acute viral hepatitis or a non-alcoholic fatty liver disease? In an acute viral hepatitis, the injury is there in the liver itself, and hence the ALT elevation will be more than that of the AST elevation, and hence the AST to ALT ratio will be less than 1 in case of a non-alcoholic fatty liver disease and an acute viral hepatitis. But this acute liver disease, when it is gradually progressing to a chronic liver disease or cirrhosis, this ratio also reverses, because the probable reason could be here is the effect of the chronic liver disease will be there on other organs of our body as well, and hence the dysfunction of all other organs will result in the production of more AST, and hence the change in ratio from less than 1 to more than 1. An abnormal increase of the AST to ALT ratio more than 5 indicates that the AST is getting produced from muscle. It could be because of the muscle breakdown. It is seen in rhabdomyolysis. Now let's look at the alkaline phosphatase. And similar to that of AST, the ALP has multiple isoenzymes, and depending on the organ that the ALP is produced from, different isoenzymes are there. So it is produced from the liver, bone, placenta, and the small intestine. So if you look at the LFT, if all the other liver enzymes are normal and if there is only an elevation in ALP, then by using two different ways, we can understand from where the ALP is getting produced from. So one method is to do the fractionation by the electrophoresis. Okay, this is a laboratory investigation where you will be able to find out what kind of isoenzyme is produced here. The another simple way is to look at the other two cholestatic enzymes, that is gamma glutamyl transpeptidase and 5-nucleotidase. If both of them are elevated, then that will indicate cholestasis here. Now we are aware that in the cholestatic pattern, we have elevation in ALP, GGT and 5-nucleotidase. Let's look at the causes here. So the cholestasis can be extrahepatic or intrahepatic. In the intrahepatic causes, we have the primary biliary cirrhosis, primary sclerosing cholangitis, and infiltration with some diseases like amyloidosis or sarcoidosis. And we have some drugs, sepsis, and total parenteral nutrition. These are the causes for the intrahepatic cholestasis. Some of the causes for the extrahepatic cholestasis are the cholelocholithiasis, malignancies like ampullary carcinoma or the cholangiocarcinoma. Then there are some diseases where the ALP is reduced. They are Wilson's disease, hypothyroidism, zinc deficiency, and pernicious anemia. Now let's look at the proteins, serum proteins, that is albumin and globulin. The albumin has a T half of about 18 to 20 days, and the decrease in the levels of albumin will indicate a chronic liver disease. Okay, because it has a longer half-life. And we have the other proteins that are the globulins. We have alpha, beta, and gamma globulins. The alpha and beta globulins are produced from the liver, whereas the gamma globulins are nothing but the immunoglobulins, which are produced from the B cells or the plasma cells. Right? And if the globulins are elevated when you're looking at the liver function tests, it is commonly implied that there is elevation in the immunoglobulins. Right? The polyclonal gamma globulinemia is commonly seen with autoimmune hepatitis and in some cases of chronic liver disease. And mind you, the monoclonal hypergamma globulinemia is seen with multiple myeloma and the other plasma cell dyscrasias, right? And then we move on to the PT and INR, prothrombin time and in the international normalized ratio. The PT and INR indicates the presence of the clotting factors 2, 7, and 9, and 10. These are vitamin K dependent factors. And for understanding here, the factor 7 T half is only 6 hours. And hence the PT and INR is a better predictor of or better indicator of an acute liver disease. Of course, it is elevated in both in acute liver disease as well as in chronic liver disease, but it is more useful for the diagnosis of an acute liver failure, right? And this is the single best acute synthetic function measure. And this is also elevated in obstructive jaundice. Why? Because the obstructive jaundice when the patient is having obstructive jaundice, the bile from the liver is not getting released into the intestine. So when the bile acids in the intestine are reduced, the emulsification of fats and further absorption of fats are reduced. When the absorption of fats are reduced, the fat soluble vitamin absorption is also reduced. That is ADAK deficiency the patient will have. And since these coagulating factors are vitamin K dependent, they will also be diminished, and hence the PTNR will be elevated, right? So the PTNR elevation is indicative of a liver disease here. Now let's move on to the bilirubin. Bilirubin is normally in the range of 0.2 to 1.5. So for the further understanding of the bilirubin, we have to look at this image here. So this is a hepatic lobule, and here is the portal tract, and you can see the direction of flow of the blood from this portal tract. What is here? Here is the portal vein and here is the central vein. The blood is flowing from the portal vein towards the central vein. And again, if you look at the image here, so from the portal vein, this is the direction of flow. This is the portal vein and here is the central vein, and this green structure is the bile duct, and this end, the right end, is the hepatic vein. So the blood that is being collected from the intestine through the portal vein enters into the liver, and in the hepatic sinusoids, the hepatocytes take up the all the solutes that are there in the portal in the sinusoids. They are metabolized and detoxified, and they are further given into the bile canaliculi, and from the bile canaliculi they will go into the bile duct. Right? This image is important to understand here for the further understanding of jaundice. Now this is a schematic picture. This is the schematic picture where we'll be looking at this red part is the circulation and this cream part is the liver, and from the liver here is the bile duct and here is the intestine, and here is the portal vein that is taking up blood from the intestine into the liver, and here is the hepatic vein, and finally the hepatic vein drains into the vena cava, of course, inferior vena cava, and then finally enters into the systemic circulation and through the renal arteries to the kidney and further excreted in the urine. Okay, this is the schematic picture. Let's look at the heme metabolism now. So the heme is converted to biliverdin and then to unconjugated bilirubin. In the circulation, this unconjugated bilirubin is bound to albumin as a carrier molecule. And when it is being delivered to the liver, the albumin detaches and the unconjugated bilirubin enters into the liver, where it is conjugated to conjugated bilirubin, okay, in the presence of UGT-A. So this conjugated bilirubin through the bile duct enters into the intestine. After it enters into the intestine, this conjugated bilirubin is deconjugated to unconjugated bilirubin by the presence of gut bacteria. And further, this unconjugated bilirubin is converted to urobilinogen and then to stercobilin. The stools are yellow because of the presence of this pigment, that is stercobilin. And this urobilinogen, some of it is reabsorbed through the portal vein and reabsorbed into the liver, and some part of urobilinogen is again is coming back through the bile duct into the intestine. This completes the enterohepatic cycling, and some part of the urobilinogen will be passing on to the hepatic vein, and then it is systemic circulation, finally to the kidney, and it is excreted in the urine. Right? So what we understood here, so in the urine we have further this urobilinogen is converted to urobilin, and this urobilin is responsible for the yellow color of the urine. Right? That is what we have to understand here. So physiologically there is urobilinogen in the urine and there is no bilirubin. Right? If you understood that, now let's look at the prehepatic jaundice. Now what is happening with the prehepatic jaundice? The prehepatic jaundice is primarily because of hemolysis. So what happens in hemolysis? The heme is increased, the biliverdin is increased, unconjugated bilirubin is also increased, and hence the entry into the liver is also increased. So what happens here is, since this entire process is occurring at higher magnitude, the urobilinogen levels also will increase, and hence in the kidney you will see higher levels of urobilinogen. But what happens to bilirubin here? Is there any leak of unconjugated and conjugated bilirubin here? No. Now, why am I talking about leak? You will understand further. So there is no leak of bilirubin in the circulation, and hence the bilirubin will not be there. Only you will see urobilinogen in the urine. Okay. This is about the prehepatic jaundice. Next, look at the hepatic jaundice or the hepatocellular jaundice. So what is happening here? The hepatocellular jaundice, the word itself tells you the hepatocellular, indicating that there is liver injury. So when there is a liver injury, the unconjugated bilirubin and the conjugated bilirubin from the hepatocytes will be leaking into the circulation. So this unconjugated bilirubin and the conjugated bilirubin will be leaking into the hepatic vein, and hence the bilirubin will be there in the urine as well. Mind you, whatever the bilirubin that enters into the urine, it is only conjugated bilirubin and not unconjugated bilirubin, because unconjugated bilirubin is not water soluble, whereas conjugated bilirubin is water soluble. And is there any problem with the urobilinogen here? Because the enterohepatic, I mean, the entry of conjugated bilirubin into the bile duct and further into the intestine is normal, and the reuptake by the portal vein into the liver is normal, and hence even in the urine you will have urobilinogen. But there is a leak of unconjugated bilirubin and conjugated bilirubin from the liver. There is presence of bilirubin also in the liver. Okay, this is about the hepatic jaundice. Now let's look at the post-hepatic jaundice. So the problem here in the post-hepatic jaundice is an obstruction, right? The obstruction is in the level of bile duct. So when the bile duct is obstructed, the conjugated bilirubin keeps on accumulating in the liver and hence it will leak, right? The conjugated bilirubin will leak into the circulation and that will result in the presence of bilirubin in the urine, right? But the point to be noted here is, since there is no entry of conjugated bilirubin into the intestine, the urobilinogen levels are also reduced, right? And hence, what do you think will be the presence of urobilinogen in the urine? The urobilinogen will not be there in the urine, right? If you estimate the urobilinogen levels in the urine, the urobilinogen will be absent, but the bilirubin will be present because there is leaking of conjugated bilirubin into the hepatic vein. So this is about the pre-hepatic, hepatic and the post-hepatic jaundice. Now in a small table, let's just summarize what happened here. Now we look at the parameters, the blood investigations and the urine investigations. In the urine, we'll be looking at the bilirubin and the urobilinogen, and finally some etiological factors as well. So in the blood, in pre-hepatic jaundice, there is only elevation in unconjugated bilirubin. In the hepatic, then the urine bilirubin is absent, urobilinogen is present. The etiology would be hemolysis or Gilbert syndrome and Crigler-Najjar syndrome. Alright. In the hepatic jaundice, we've seen that there is elevation of unconjugated bilirubin as well as conjugated bilirubin, and the bilirubin will be present here, and urobilinogen will also be present here. Any kind of hepatitis can result in hepatocellular jaundice. And then post-hepatic jaundice. In the post-hepatic jaundice, you can see the conjugated bilirubin is elevated here. In the urine, you will see bilirubin because of the presence of conjugated bilirubin leaking into the urine, and then urobilinogen will be absent, right? And when you look at the etiology, any bile duct obstruction we have seen, and we'll further see some of the causes of the obstructive jaundice here. Now, what are the usual patterns of derangement of LFT? So there can be an isolated bilirubin elevation, there can be a hepatocellular pattern, or there can be a cholestatic pattern, and sometimes there can be an isolated elevation in ALP. We have seen that in isolated elevation in ALP, what we have to do either GGT and 5-nucleotidase, or you can do the electrophoresis, right? So if there is an isolated bilirubin elevation, you have to look at the direct bilirubin. See, when the direct bilirubin is less than 15% of the total bilirubin, we call it as indirect hyperbilirubinemia. When the direct bilirubin is more than 15% of the total bilirubin, we call it as the direct hyperbilirubinemia. So when the patient is having indirect hyperbilirubinemia, again re-insisting here, when the direct component is less than 15% of the total bilirubin, we call it as indirect hyperbilirubinemia. When the direct component is more than 15% of the total bilirubin, we call it as the direct hyperbilirubinemia. Here, when the patient is having indirect hyperbilirubinemia, the probable causes could be the presence of drugs like probenecid and rifampicin, hemolysis resulting from any cause, and Gilbert syndrome and the Crigler-Najjar syndrome, right? So, and the direct hyperbilirubinemia, isolated direct hyperbilirubinemia can be seen with Dubin-Johnson and Rotor syndrome. Now look at the hepatocellular pattern and the cholestatic pattern. When do we call it as the hepatocellular pattern? When the ALT or AST elevation is in out of proportion to that of ALP, right? The elevation in ALT to AST is in out of proportion to that of ALP. You call it as a hepatocellular pattern, and that is seen in various diseases that will result in a liver injury. And hence you have to evaluate for them. So how do you evaluate? First, take the drug and toxin history, whether the patient has taken any drugs or toxins, and then you have to go ahead with doing viral serologies to exclude the causes of viral hepatitis, and then serum cellular plasma to rule out Wilson's disease, toxicology screen, to look at the toxin intake, ANA, that is anti-neutrophilic antibody, SMA, smooth muscle antibody, and serum protein electrophoresis to look at the ANA and SMA will be elevated in autoimmune hepatitis. And then the cholestatic pattern. So if you find that there is a cholestatic pattern, the cholestatic pattern is not just elevation in ALP along with 5-nucleotidase and GGT here. If the elevation in ALP is in out of proportion to that of elevation in ALT, then do an ultrasound, right? If there is any dilation, what you are going to look at in the ultrasound, you are going to look at any dilation in the bile duct. If there is a dilated bile duct, then the probable cause could be an extrahepatic obstruction, right? Then do an MRCP to find out the cause for it. But if there is an undilated bile duct, then it could be an intrahepatic obstruction. So for the intrahepatic obstruction, what we have to look at is an anti-mitochondrial antibody that is elevated in primary biliary cirrhosis, and again you have to look at the viral serologies and some drugs that can also result in cholestasis, right? So after we did all these investigations, if you are not able to find out any cause for it, then the final resort will be to do the liver biopsy. At the end, if you do the liver biopsy, that will tell us what kind of liver injury that the patient is having. Okay. This concludes our short lecture on the liver function tests. I'll see you in the next video. Till then, bye bye.